Okay, so the purpose of this talk, and it is a little different color than what I had, but which proteins are not working? That is the idea. And as you know from sitting in this room, there are potentially many different proteins that are not working, but there are also plenty that are working. And I want to go through the plan for the talk in case I don't pull it off. You say at the end, well, now what was she doing with that set of slides? But if at the end of the day, you guys know the basics of muscle, proteins that allow muscle to function, a little bit about the history of limb-girdle muscular dystrophy, and for those slides, I'm grateful to Sarepta. They gave me a few background slides that were well done, and I modified them. You'll see that as I go through. And the 2 ways limb-girdle progress, and why and how to know your genes, and why and how to know your neighbor's genes. And I think I skipped over, but I shouldn't have. My disclosures all relate to muscle disease, but I own no stock in any company, and all of these are advisory groups where we're trying to translate genes, translate medicine for therapy for SMA and Duchenne, and actually limb-girdle muscular dystrophy as well. So I'm a site PI for a few, and I serve on some advisory boards, and I manage one data management safety board for Duchenne study. Okay, so the basics of muscle, I have a volunteer who graciously agreed to come and help. I give this part of the talk to medical students, so if you think it's too simple, I don't think it is. I think muscle is interesting and complex, but before I have my volunteer show you something, I want you to notice that, you know, we all know what our muscles, we think we know what our muscles do, but when you think about them individually, some are responsible for your face and how much you can smile. Other muscles, the so-called core muscles, are responsible for how well you can breathe or sit straight. And still other muscles are responsible for how you walk. And finally, whether you can walk and run fast. So to see all these integrated, you can turn on a track meet, and you can see a lot of these integrated. But for our purposes, I've asked Sarah to kindly volunteer to pretend she is an Olympic sprinter, and she's going to do the 10-meter dash, and she's going to get down low, because that actually, in order to run and get down low, it requires hip and back muscles. And then as she comes forward toward me, and maybe she'll jump right on the stage, it's going to require her more distal muscles. But she has to have both of those sets of muscles working in order to sprint. So Sarah's going to do this twice for me. We agreed. So here you go.
Was that good?
Yeah, that was excellent. And do it once again. So remember, she can't. You can't. Yeah. Do it on that side, and you can just go right up the ramp. That would actually work. But so way down at the beginning, she's using hip, and then she's going to use distal muscles. Go. And as she goes up, she's also using her arm muscles to get more power, and that's exactly what we see again and again. Say that. I agree. So again, starting with the basics, you guys all know what your muscles look like when you look at them in your arm. And as we go closer and closer down, actually I think this thing does work. As you go closer and closer down into the muscle, we have these, we call them tubes or fibers, and they're little groups, and they're working as a group. And then if you go further and further down and you take a single muscle fiber, you can get to this picture. And at this picture, you can begin to know exactly which proteins are involved. And you're going to see more of that in a second. Now, if you're a 2D thinker, you can look at the figure on your left, and you can see that for muscle to contract, it's got to get shorter. If my biceps is out like this and I bend it, it is physically shorter by several inches. So if you're a 2D thinker, you would think on the left, and you'd say something must be pulling together to make it shorter. If you're a 3D thinker, you will look at the figure on the right, and you're like, wow, there's got to be stuff around and about. Everything has to be coordinated. So how does that work? Well, it's really quite simple. What could possibly go wrong? So this is, and please take notes, I'll stay here for 10 minutes till you've written all of these down. But no, these are actually just a list, and not only of limb-girdle. These are a list of the things that can go wrong at the nerve-muscle junction, for Duchenne. These are all the things that can go wrong. And if you're a more visual person, as am I, this is one of several schemes I'll show you that try to get at exactly what is happening. What could possibly go wrong? Any one of these can cause a muscular dystrophy. In some cases, and we're going to focus on today, the causes of limb-girdle muscular dystrophy, but I'll convince you that just as the MDA is all one team, people with muscular dystrophy should all be one team as well, because lessons learned from one will translate to others, and I'll talk more about that in a second. The limb-girdle muscular dystrophy, all of these locations are things that the limb-girdle muscular dystrophy affect, and there are some more that aren't on this relatively simple diagram. Okay, let's make it a little harder. This is an incredible team of proteins. The ones on your left so if you think about it, and just to keep you occupied so you don't have to stare at the picture, I want everybody in the audience, while I'm talking about this slide, it's going to take about a whole minute, to just open and close one hand while we're talking, because I want you to think about what's happening and what we now know is happening. You don't have to do it tightly. You can just open and close. So as you open and close, your brain sent information to your nerve. And there's your nerve. And it sent information to this, which is the nerve muscle, the end of the nerve right here. And then it sent information to this nerve-muscle junction. And the muscular dystrophy also supports all of the disorders from this group. We're not going to talk about any of those today. But these are all of the nerves, all of the proteins that support this, the nerve-muscle junction. You can't have that. Working, not working, open and close. If that isn't working, it doesn't matter about the muscle. But for our purposes, we're going to talk now about, we're going to talk now about the proteins. So all of those other things are already happening. Remember I told you lots of things are going well. Your brains are going well. Your eyes are doing well. Your ability to send the signal to your nerve muscle junction, all of those are going well. And it's useful to remember that. Okay, so this is a little, we're going to stop now and just go through a little bit of history. And if you know history, it helps you understand why you might think limb-girdle muscular dystrophy is a bit behind compared to other disorders. Because way back in 1861, Duchenne, who was not the first to describe Duchenne, but Duchenne is the most famous, of course, for having described boys. Why did he so quickly do that more than almost 100 years before the term limb-girdle was coined? Because there were lots of them, and they all looked the same. And he was a clinician, and they were all boys, and they were all presenting between age 4 and 5 or 6. So sure, pretty easy. You see it again and again and again. I often joke that I never diagnose Duchenne. The pediatrician always diagnoses Duchenne because they're so uniform. But it was in 1954 when John Walton and a colleague, I'll show in a second, described or coined the term limb-girdle, because he said these are not little boys. These are sometimes girls. These are sometimes women, men. It's quite variable. So he described that. And then we, from 1950 to 1990, into the 90s, one by one, we started saying, oh, this is the gene for that. This is the gene for that. Whereas in 1990, Duchenne was discovered, and then all of these other ones were following that. In 1995, the European Neuromuscle Consortium established some names, and we're going to talk about names in a second. And then there's another naming classification that just came out this year. Okay, So a bit more about that history. It was the other fellow whose name I had temporarily forgotten is Natras, and I always like to give both people credit because they thought about the characteristics that all of you are living with. And that is that these muscular dystrophies are quite distinct from, others. And I realize that, yeah, these classes would have been good. But sorry to, so you have progressive, these folks have onset anywhere from early childhood to kind of late adulthood, even into the 7th or 8th decade. The weakness is, however, progressive. It tends to be in the hip and shoulder girdle, but you'll see there are definitely exceptions. And they also notice that it's different from one area of the world to another. So global prevalence data puts it at about 1.6 per 100,000. And this slide I did modify because it's what is the genetic basis of limb-girdle and why you and I and everyone might be confused. Okay, we're going to do this. Just take a minute to think about this, but a lot of you guys already know. Autosomal dominant means one directly from mother to child, or it can show up in a child for the very first time. Autosomal recessive, both parents are usually well, but it shows up in the child for the first time, so no family history at all. And what was, what we used to do is call that limb-girdle muscular dystrophy type 1 and type 2. Type 1 comes from one parent, 2 takes 2 parents, so it's recessive, if you want to think about it that way. And all of us in the field tried to memorize this. And that's when things got complicated. And because as soon as a new one was diagnosed, it was given a new letter. So limb-girdle 2, recessive, first one described, limb-girdle 2, 1, limb-girdle type 2, 2. Limb-girdle 2, see, even I. But this last diagram, which I tried to make bigger and probably should have made still bigger, is the new, most recent nomenclature, and you're going to hear more about that, but it's a little more logical. It's limb-girdle muscular dystrophy R for recessive, or limb-girdle muscular dystrophy D for dominant. So start with that as your beginning. And then, in the order they were described, 1, 2, 3, 4, 5, 6, 7, 8, 9, what are we up to now? 33. So the alphabet ran out. The alphabet ran out, which is why that first system was terrible. They were going back to AA or BB. Can you imagine? So it's now, our number system won't run out. There are 33 in the recessive category. And that's what we now use. Okay. One fun fact for the people who are interested in genes and why these things happen, and I use Denmark as an example, it was noticed, people around the world noticed, hey, we're seeing more of this type in Denmark, or we're seeing more of this type in Ireland. And it was discovered that in certain disorders there were founder effects. That means way, way, way back when, maybe 20, 30 generations ago, a single gene broke, but it became prevalent in that community. So we know, for example, that limb-girdle 2I, which is now known as limb-girdle DR-9, which is also known as fucotin-related protein kinase deficiency, is more common in Denmark. And when it presents in Denmark, it tends to be a little milder, adults. When it presents in other places, it's different mutations, and so it can present as a child. So the highlights of limb-girdle D1 and limb-girdle D2, or now limb-girdle DR and DD, is that limb-girdle, the dominant forms are less common. They make up about 10% of everybody, and 90% have recessive forms. One thing you'll see on this slide and in every other one is that age of onset, variable. The recessive forms tend to be a little bit earlier, but on average, it can be anything. Creatine kinase, which is a muscle enzyme we look at for turnover of muscle, is mildly elevated in the milder forms and can be very elevated in the more severe recessive forms. Twitchy, sorry. Okay. If you don't want to look at the whole slide, just read the word variable and talk to your friends at the breaks. All of these are extremely variable. These are the features. They're variable disease progression. They're variable distribution of the muscles. They're variable with regard to age of onset, as we just talked about. And they're certainly variable with regard to whether breathing or heart will be involved. Each one is different, which is why you must know your own. CKs are variable. That is the most important thing, and it's also the reason that when I was just became a neuromuscular doctor in 1990, my boss said, limb-girdle muscular dystrophy is a terrible term. It's a quote-unquote wastebasket term for what we don't know. And so we would say it's somebody with weakness who doesn't have Duchenne. It's somebody with weakness who doesn't have myotonic dystrophy, because we knew what those look like. So it was, quote unquote, a wastebasket term. And I'm very proud to stand here today and say I have no picture of a wastebasket. This is actually a set of disorders that science has slowly moved forward, and now in the last 10 years quickly moved forward to understanding and identifying exact causes. I'm going to use two examples, and I'm going to use two examples of what can go wrong. And I think I would be taking the entire day if I did every disorder. But for our purposes, we're going to use alpha-sarcoglycan deficiency, which is limb-girdle MDR4 or limb-girdle 2D, of course, caused by alpha-dystroglycan. So everybody would memorize that with the old system. The sarcoglycans are these, oh shoot, sorry. The sarcoglycans link the outside of the muscle to the inside of the muscle, and there they are lined up. You can see there's lots of other things in the neighborhood, and we know some of them well. We know dystrophin. We know some of the ones that cause congenital muscular dystrophy. But if you're missing any of the sarcoglycans, it will lead to a form of limb-girdle muscular dystrophy. What is the weakness pattern here? The weakness pattern that we know about, and the picture that is usually shown is this one from the front, where the quads and hip flexors are weak, and the shoulder muscles are weak. But I encourage you to look at the back of the muscles as well. And this young man has this, and his shoulders are weak. So ability to pull his arms up or turn his arms back, they are definitely affected by this. So now we get to know why it happens. This is, again, medical school slide. But if you understand this, you'll understand the strategies that people are using. This protein complex, this dystrophin glycoprotein complex, allows those muscles to bend up and bend down and not break when they do it. So bend up, bend down, open, closed, back and forth, back and forth. And so all of these, this dystrophin glycoprotein complex allows the skeletal muscle fibers to squeeze and relax. If a single part of it is missing, that connection is lost. It might happen at part, but not others, and therefore the muscle is very sensitive to damage. And chronic damage, muscle is great at repairing. If we did this to our brain, we wouldn't be doing so well, but fortunately, muscle does repair itself. So even, if somebody, you bang your leg or you bang your shoulder, you'll get a big bruise, your muscle will be sore, but it will repair itself pretty quickly. Whereas, but if that happens again and again and again, that repair mechanism cannot keep up. So what does this look like? Yes, this is a slide I show the medical students. It's a courtesy of a colleague of mine in the Netherlands. But it's here's what it should look like. in this picture, this is outside your muscle fiber. This is inside your muscle fiber. So if all is going well and the water floats up and down, the outside and the inside, proteins on the inside, proteins on the outside are linked. They're doing just fine. No matter what the water does, no matter what the muscle fiber does, they stay linked. And if they don't stay linked, everything gets disconnected. So there's tearing that happens. There's a disconnect, and that muscle fiber will look damaged. And now I get to show you your first pathology lesson. So here's what it looks like to us under the microscope. And I don't expect anybody to be very interested in these slides, except you, actually there's a young person in here who will know more about muscle than anyone else in the world his age, because it's not very complicated. If you look at the bottom right, this is what normal muscle looks like. This stain called an H&E is done in high school, even grade school. It takes about 5 minutes to do. You take a little slice of muscle, cut it sideways. We talked about all those long tubes, but now you're looking at the tubes on end. So you sliced it, and you're looking at one little tiny slice. And of course, if you sliced up a bunch of tubes, it should look like circles. And these circles are all about the same size. And that's normal. The dark dots are the nuclei, and they're right where they belong. But if you look at somebody who has alpha-sarcoglycan or any other limb-girdle muscular dystrophy, this is what their fibers will look like. Some are just about right. Look at that guy. It looks perfect. He has not snapped or broken. He's still functioning. But some of these are really small, and that means that they broke and they're repairing themselves, and they're small. And for Nick in the room, we have some nice regenerating fibers. We know they are small, and if you look closely, they're slightly darker purple. So slightly darker purple than these guys. So that's a regenerating group, and also their nuclei are very big. So we can look at that and we can say, this muscle is regenerating, but if we look closely again, we see this guy. See that big pale pink one? That is terrible. That is a dying or dead muscle fiber. Now it's gonna repair, but if you have too many of those and not enough of these, you'll have progression of your muscular dystrophy. Okay, now, so that's one way your muscle breaks. The second way, another common way that happens in limb-girdle muscular dystrophy, we're going to talk about limb-girdle 2B, which is now known as limb-girdle MD recessive 2, and it's caused from dysferlin. And this is a picture from Corrado Angelini in Italy, but the woman demonstrates a couple of things. She's got shoulder weakness, and she's got some quad weakness, but she also has extremely skinny legs. So her presentation in this muscle is a little more distal than proximal, but she does have both. Only 450 mutations have been found in the single gene. And as you can imagine, there's my favorite word, variable. Some of them present as infants, and some of them can present well into your 70s. Leg weakness is very prominent, and it's the gastroc, the sprinting muscles that Sarah so beautifully demonstrated that would be affected. So she would be able to do the first part of that pretty well, but she wouldn't be able to pick up any speed. So these are your speed muscles. These are a couple more pictures of the same thing from Ellen Pestrunk's website. Again, you have to get used to looking at the backs of legs, but the gastroc should be more prominent here, and the quad can be affected. And if I show you this, I wouldn't expect you to say anything different than the last pathology I said. I tried to find one that would look very different. They all look the same. These are all from Dr. Pestrunk's website. But the interesting thing, if you look closely now that you're a pro, you can see, there's a fiber that's degenerating. It's too pale, too pink. And if you look down here, you say, oh, look at that fiber. It's very dark. It's regenerating. It's got a big nucleus. It's regenerating. So repair, regeneration, we just see a snapshot of it when we look under the microscope, but it's happening all the time. Okay, so those limb girdles, dysferlin and anoctamin 5, are caused by basically a lack of the repair mechanisms. And this is where I get to talk about, I think this slide or the next one, we get to talk about why I believe the approach to moving forward in science is for everybody to be on one team. So let me tell you that these, you can take it as my word, that what happens is they do not repair fully. And failed muscle repair leads to that balance being off. Too much degeneration, not enough repair. But in the lab, how can you test repair? Well, you can test it with this little laser. This is just a high picture of a muscle that somebody like dinged with a little laser. They made this little tiny hole right here. And I'm going to tell you in a minute why I've covered up this. But if you ding it, you could, depending on the conditions, you can get a pretty good size hole, smaller, smaller. They can vary. The holes can vary. And this is from Connolly's work, and you're going to see another picture of that. But this is one way that you test repair in the lab. Okay. So put all that aside now, because now you have to know your own gene. And I apologize for those of you for whom this is too simple. But it's really about knowing your ABCs, and in this case, it's the ACTGs of limb-girdle muscular dystrophy. So we all know the dystrophin makes protein, makes RNA, makes protein. That happens in the cell. It's happening for all of the proteins. It's happening for the proteins at your nerve muscle junction everywhere. It's happening all the time. And we also know that a codon is 3 letters. So DNA transcribes to make messenger RNA, and then that translates, because it's a whole different language, into all of the proteins that we need. Okay, this is the reality of how I explain it, and I do use this exactly when I explain it, because if you need 3 letters to make sense of things, you can make up a little sentence that has 3 letters. In my case, I made up the sentence, the fat cat ate the red hat. And you can imagine that if the fat, 3 letters, exactly 3 letters, one tiny little exon that's in frame, as we call it, is missing, you will have a sentence that reads, the cat ate the red hat. Well, we don't know that he's fat. You might imply it if he's eating cats, but he ate the hat. He ate the hat. We do know that, and he ran off in this case. So he did everything else he was supposed to do. That's a protein. The cat ate the red hat is the protein. It's doing everything it's supposed to do. It's hooking up to the other proteins. It's not doing it perfectly, but pretty well. So there's some expression. Whereas if I have a mutation, if by chance the gene broke in such a way that the E is also missing, so the E from the word the is also missing, the blank ate the red hat, then I would have, my gene doesn't know how to read anything but 3s. So it's going to read THC, and then it's going to read ATA, and we can see that makes absolutely no sense. The body says, that makes absolutely no sense. I'm going to throw this protein away. It's no good. It's not going to fit or hook up with anything that it's supposed to hook up with. And that is the way mutations work. Okay, now this is my neighborhood slide, and I flash forward from about 120 years from when Duchenne described dystrophin. Here's what we now know. We know a lot. We know all of these different things, and these are the ones that are in the neighborhood. And the science, when a scientist picks someone, like take one and they run with it, But they've known all along, as we've learned more and more, all of these others are in the neighborhood, and that becomes relevant for my next slide. Why I believe you should know your own diagnosis, but you should also know your neighbors. This slide is again from Alan Pastrung's website, but it has just the limb-girdle muscular dystrophy ones on here. And the reason you should know your neighbors goes back to the history. And we're back at the same slide, except for I changed it a tiny little bit. And we still have Duchenne discovering this here. We still have Dr. Walden. I'm sorry I dropped his picture. But we also have, when I came into medical practice, which is in the 90s, and in 1997, 1998, we had a child who had presented at age 8. She had weakness, but her family said, she's only been weak for a few months, maybe a year. Maybe they noticed it in soccer. They weren't sure. Her biopsy was like the one I showed you. It had inflammation, it had turnover, and my boss thought that she had a treatable muscular problem, which is an inflammation, which is quite common. And so he treated her. But a couple years later, as science moved forward, we were like, wait, she looks too much like this other condition. She's not the only one who ever got immunosuppression, but he allowed me to write her up, and the reason he did is this. So she was a child with primary alpha-dystroglycanopathy who really responded to both prednisone and azathioprine. So here she was. The yellow is her arm muscles. The blue diamonds are her leg muscles. This is pounds. And she's starting in here, I can tell you 10 or 12 pounds of quads in an 8-year-old is very bad. They should be 30 or 40 pounds. But very quickly, just with the prednisone alone, those two, everything went up. Even her distal muscles went up. And then he treated her for, this is 3 years. So over 3 years, she stayed stronger than her baseline. And she's just a single case report. But it always begs the question of, should we be treating, what should we be learning, what should we be learning about other disorders? And that then brings me to this question, which I asked when I was putting this together, because I haven't spoken about limb-girdle muscular dystrophy as much, but it has frustrated me because I take care of patients with this all the time. Why aren't there more clinical trials? And I want you guys to understand, number one, there are 34 different ones. Everybody wants to tackle one. You can't tackle 34 at the same time because they might have different rates of progression. There's that variable, which has now become, while it's good if you're on the mild thing, variability in clinical trials is terrible. But the other thing what I mean by that is physicians are only now getting really fast at diagnosing them. Many of you in this room, I can promise, did not know your diagnosis for 10 years, 20 years, sometimes even 30 years. You just were in that limb-girdle muscular dystrophy until you knew what it was. So we're getting faster. Science is allowing us to be faster. And then but because of this, I think we should still be able to learn from other disorders. So you're going to learn a lot about that today, so stay tuned and pay attention to neighbors and mice. And I'm going to cycle back to this picture, which is a slide I used when I was talking about Duchenne. We know corticosteroids work in Duchenne. We've known for a long time. I and others tried to figure out why, but Dr. Quattronelli, I think, has sort of begun to understand the question. And it's got to do with what happens when you make a laser print, a laser here. With steroids, the hole is smaller. This is control, and these little holes are much, much smaller. So you're more resistant to damage, the same little laser in the dish. And then the other fun fact for me is that he showed that if you give it every day, it's probably not good for you. It makes the muscles smaller, and you can measure the size of one particular muscle in the mouse, the diaphragm. So it makes your muscles smaller. They both help repair, but one of them makes your muscles too small. But if you just give it intermittently once a week in the mice, And you say, okay, we now want to talk about Duchenne. So this young man who I've met and is delightful turned right around and did the exact same thing in 2 models of limb-girdle muscular dystrophy and proved that this concept is the same for Duchenne and for 2 forms of limb-girdle muscular dystrophy. So it is possible that there are other treatments or not, what I would call non-mutation specific treatments that may become available or may be studied more carefully in the future. Oh, sorry. So I get my last slide is my dream slide. It's the same no matter what talk I give. I have those are like dream catchers from American Indian. They're like a little thing, you put it in the wind and you catch your dream. So the dream catcher is made by Native Americans, and the idea is that we may have screening as part, we may have newborn screening, we may find limb-girdle early, we may identify the type and know when it's going to show up and what we should be doing about it early. And even if we cannot do something about the gene itself, maybe there will be what I call non-mutation specific therapies in the future. So thanks, guys. That's it. And save questions for the end, I think.
So, thank you, Fan. That was a wonderful little talk. Does anyone have any questions for Dr. Connolly? We probably had 3-5 minutes before break. If we need microphones, we have microphones. We can walk around. If you want to raise your hand, we'll have someone come around with the microphone so you can ask their questions. We have a couple over here.
1, 2, 1, 2.
Most of the discussion was concerning the recessive. What work has been done on the dominant?
So actually, there's really beautiful and equally compelling work on dominant forms as well. The dominant forms, the pathogenesis of those are also understood. Most of them also have repair mechanisms, either regeneration or repair. So it's still a damage piece. That there's still a damage and repair. I chose 2 that give you kind of 2 ideas of what, but the whether it's Duchenne or Becker or myotonic dystrophy, which is a dominant one, or FSHD, which is dominant, it is the repair cycle. We do know that in some forms, some dominant forms of limb-girdle muscular dystrophy, the concept of variability is exactly the same. We know a little bit more about that genetically. For example, we know that the size of the mutation in certain cases predicts whether you're going to show up as a child or show up as an adult. But the basic mechanisms of turnover of muscle really are equal opportunity. They're very similar from one to the other.
I think you answered my question, because I was wondering about the dominant too. But also, mine has never been diagnosed as, I guess they're guessing it's limb-girdle. So there are situations like that too, where you do not know.
Yes, and I think we're going to have a talk from a genetic counselor who's going to help us with that, but you're absolutely right. Despite, for example, in dysferlinopathies, knowing 405 mutations, there's still work that's being done and databases that are being studied. Almost not a month or 2 goes by when we don't understand a little bit more, or something they thought was not really a mutation is a mutation. And to make life even more complicated, sometimes if you have a tiny break that wouldn't matter in a different gene, but you have this other problem, you could have a little tiny problem in 2 genes. And there are folks who are trying to understand that as well.
Yep. We have time for one more question. All right. Thank you,
Thank you.
Dr. Connolly, really appreciate it.